Hi everyone. Welcome to Healthcaring Differently. We are about to start in a few minutes. Hi everyone. We're just having just figuring things out. And I am, sorry, one second. I am just gonna let KD in. I'm still learning how to do these things. Okay. And I have to I'm inviting myself to join, which is a strange thing. There we go. Hi.
Hey, Dr. O, how's it
I
going?
am well. How are you?
I'm pretty good. I'm looking a little shiny today, but that's all right.
I'm always shiny. Okay, I'm just getting things settled. We have folks joining.
Oh,
One second. We're just having some technical difficulties. I think we solved it. There we go. Because we have to do the join from multiple platforms. Can you hear me okay?
I can. Yeah, you sound great. It's good to see you again.
Yes, good to see you again too. I know we have to start in a serious note, but just side note, I was very sad when I had to give the airport people the jerk sauce.
Oh,
So
yeah.
they didn't let me bring it on the plane. Anyway, we'll talk
Classic.
offline. I was like, really though? I'm like, it's more of a paste. Anyway. I tried.
Next time I'm in Toronto, I'll bring you some.
Thank you. Okay, so it is 7:01. We should be serious grown-ups and start for real. So let me do the intro stuff, okay? So hello everyone. My name is Dr. O, and I am the host of Healthcaring Differently, where we are talking about healthcare and what it's like to be different and practice differently. I'm always saying some people struggle to think outside of the box, but y'all, we were born outside of the box. So thank you. So please do tune into our IG Lives, which are every Tuesday, but also keep in mind that we're going to have a monthly newsletter where you can get information on how to stay connected on the different resources that are available and pathway programs, research opportunities across the country. My guest today, just one second, I'm hearing an echo. Okay, maybe we can do something about that. Okay, so my guest today is KD, KD King, whose pronouns are he, they. And KD is a proud ayahkwew. Did I get that? Ayahkwew?
Yeah?
Yes. Two-spirit registered nurse and researcher from Notikewin, Alberta, in Treaty 8 territory. They are descended from English and Russian settlers, and their mother and grandmother were Métis nurses and healers. My grandmother was a healer, too. KD is a PhD candidate at the University of Alberta and teaches at MacEwan University. Their interests, you can put it outside. Their interests include sexual health, leadership, health equity, Indigenous health, mental health, and substance use, and gender and sexuality across the lifespan. Welcome, KD.
Thanks. It's an honor to be here. It's really good to see you.
Yes. It's really lovely to have you here. We really connected when we met at the the CPAP conference, the Canadian, what is it? The Canadian Prevention
Partnership Against Cancer?
That's it.
Yeah.
And we clicked there, and I'm so glad that you were able to join on Healthcaring Differently. So, I think it would be really helpful for our audience to hear about your origin story.
Yeah.
What brought you to nursing, to research, to the areas that you focus on? Do you want to talk a little bit about that?
Yeah, you bet. So, as you mentioned, I grew up in rural Alberta, up north. I grew up on a farm, a big farm with lots of cows and lots of land all around, and not a lot of people. But as a queer Indigenous person, who's also very white, there were kind of unique. I occupied a unique space in my community, and so fortunately, I was pretty good at school. So it was an expectation for me to go to university. I initially had wanted to be a doctor. I remember when I was like, well, a doctor scientist. I was, I think, about 4 years old, and my uncle had polio when he was a kid, and he was in a wheelchair. And my little 4-year-old brain was like, oh, I'm going to become a doctor so I can cure polio. Well, my parents were happy and sad to tell me that it had already been solved, the problem.
Somebody's done it already.
Yeah, but you know, as I was growing up, I fortunately was good at science and math, and so when it was time to go to university, I did have intentions to become a doctor or a veterinarian or something along those lines. Got to university, you know, coming from the small town, I maybe overindulged in the partying and the um, figuring out what city life was like and being on my own. And so I didn't have the grades to get into medical school at the end of my biology program. And then a friend of mine had gone into nursing from the biology program, and she said to me, "You're really good at like all this stuff already. Like you probably could be a doctor if you didn't party so hard. But why don't, you know,
None
your
of us
mom's
do
a
party
nurse."
hard, but go on.
I know. Your mom's a nurse, your grandma's a nurse, like you already know what it's like to be in a hospital. You grew up around hospital stuff. Like my mom was a CPR instructor, so I knew CPR from about the age of 10 because she
Oh,
taught us all CPR. My grandpa died of a heart attack when we were very young. He was very young too. And my grandma actually did CPR on him. And so it became very, you know, our whole family was CPR trained at a very young age.
okay.
And so then I went into nursing, and sure enough, I loved it. Honestly, it was like the best choice I'd ever made. I was really good at it. And yeah, I've never looked back. I've had a really amazing career in nursing. And a few years after I graduated, I went to grad school to do a master's in public health epidemiology down in Australia. And that was really cool because I was interested initially in sort of health communication stuff, but like everything you do in school, the more you learn, the more your ideas change about what you want to do. I'm
Yeah.
sure you experienced that too with med school. Like every rotation, you probably were like, "Oh, I'm going to be a plastic surgeon," or you know.
Yeah. I was gonna be an obstetrician gynecologist. I was also gonna be a an ear, nose, throat
Okay.
surgeon, like all kinds of stuff before
Yeah,
I landed it. Yeah.
of course.
Yeah.
So I started off in health communications, health promotion stuff, and then I got really interested in infectious disease epidemiology because I was volunteering with an AIDS organization. And so I was really interested in HIV. I ended up doing my research on the intersections of mental health and HIV in England, in East London. And that sort of got me into the sexual health realm. I had
Oh.
previously been working in psychiatry a lot.
Mm.
And then when I moved back to Canada, I decided to go back and do my PhD. And I had a family member had experience with HPV-related cervical cancer. So again, a little shift in my path, but it's
Yeah.
still, you know, it's still on the general route of like sexual health and Indigenous health. And yeah, anyway, it's
Yeah. I mean,
been amazing.
yeah, and I think so. I mean, there's so much to unpack there because, first of all, I think, I mean, part of it was okay. You were told if you party too much, you can't be a doctor.
Right.
So number one, there's a lot of us who party or who partied, especially back in the day, quite a
Yes,
bit.
back in the day.
But also, I think there's the piece around like the work that you're doing as a nurse, and then now as a like PhD researcher or research student, but researcher, you're doing the work regardless. It's so important that we recognize, and that's part of healthcare differently. Not only the diversity of our, like ancestry, but also the diversity of roles that are required to come into healthcare, to be able to treat people, to be able to bring the different, like responsibilities and things like that into care. And so, yes, like for some people, it is medicine, and for some people, it's nursing, for some people, it's physiotherapy.
Absolutely.
For some people, it's engineering and health. And we're going to cover all of those
Yeah.
things over the next few months of healthcare differently. But like I don't know if you have anything to add
Yeah.
about that, because I feel like
Well,
people think everybody needs to be a doctor, and that would be a scary, scary place if everybody was.
totally. I agree. I mean, everyone would die after their surgery. But as a nurse, I think about the roles that we have in hospitals and in healthcare broadly, whether it's in the community or even in like private sector. I always say this to students. I taught leadership for a couple of years, and I always say to students, getting a degree in nursing really opens the door to do almost anything. And it's very similar, I think, to medicine, physiotherapy. Like you can literally apply the skills you learn in these health professions, both to your everyday life. Like I always say, they're skills for living. Nursing skills are skills for living and staying alive. But
Right.
also, they're really useful skills in just about any profession. I know nurses who work in the oil fields here in Alberta. I know nurses who work in the insurance industry, in like supercomputing and AI. Like there's so many applications of this health knowledge that you get as a health professional. And there's a shift, I think, towards interdisciplinarity too. Like nowadays, more and more people are working in interdisciplinary ways. So we have engineers on the team, we have computer scientists. Um, I did some work with oncology a few years back, and the like medical physicists and the radiation, like just so many engineers
Right.
and
Yeah.
like different people that are all working together to solve cancer, and it was really really cool.
Okay. No, I mean that's it. It's so broad, but at the same time, I think So as much as there's layers of diversity, right? So there's the diversity of like our roles on the team, but let's kind of like come back to like the path that we walk. And so you do have like this mixed ancestry of the English and Russian settlers, but also the Métis like nurses and healers, and like you said, like learning CPR at that young age. But then there's like the healer piece that's more traditional or more ancestral, or Indigenous and Métis ancestral. So for you, do you feel like that plays a role in how you healthcare differently, like how you are
Yes.
practicing
Yeah,
now?
absolutely. I just saw my niece just join, so I just want to say a big shout out. Hey,
Hi.
Dad. But also, yeah. So, I grew up in a time when it wasn't really cool to be Indigenous in Canada, because I'm a little bit older probably than most of the people on this. But I really came into my Indigenous identity a little bit later in life. But through that process of connecting and reconnecting with elders and knowledge keepers, I've been able to integrate a lot of that traditional knowledge into my practice now. Like I was working for a little while as a designate nurse for HIV here in Edmonton, and I had a lot of First Nations and Métis clients or who I worked with, and we would incorporate smudge and traditional medicines into our work together, and it was really beautiful. It's a really beautiful way to connect with people. And as a white Indigenous person, often I think there would be a skepticism with some of my Indigenous relatives who were
Mm,
like, "Hey, what's this white guy doing with sweetgrass?"
right.
But then it's also a process of unlearning what it means and what it looks like to be an Indigenous person in Canada, because there's Black Indigenous people, there's white
Yes.
Indigenous people, there
Yeah.
are people across the color gradient, and so it's been a really beautiful process of learning and incorporating that. And then additionally, my queer identity as a two-spirit person and what that means in community as like a servant to our community and as a healer, and community advocate. Those are all like aspects of my identity that I'm so grateful to have integrated into my work. But it took a long time because it hasn't been easy to be a queer Indigenous person in healthcare in Canada.
No, I mean, I can only imagine. I can only imagine because of that intersectionality and all of, I mean, the way we practice medicine and healthcare is very colonial, right?
Yeah.
Um, and where you mentioned kind of the two spirit identity, but now you've come to the point of embracing it. And I'm curious about what you mentioned to me, offline around like inclusive gender affirming care for everyone.
Yeah.
um, that piques my interest because when I think of gender affirming care, my mind goes to making it affirming for people who are non-binary and trans. And honestly, just like anything else, I think that would be like my primary concern. But I like this idea also for everyone because often when we change our ways and do better to uplift, a group that is in the non-dominant role, everybody benefits in some
Yeah,
way, but we need to not forget that group as our primary group
yeah,
though,
yeah.
because that can happen too.
No,
But yes, so talk to me about it. I'm excited about what you have to say
absolutely.
about this.
I literally just did a workshop this weekend about this. I was at a Métis gathering for Indigenous women, and I was asked to do a workshop on gender affirming care. And I think when you get a group of cisgender people together, they think it's going to be about surgeries and hormones,
Mm.
and what we really did is break down, that every person, from a decolonial lens, we all have a gender. I
Mm.
remember being in a meeting a long time ago, and a colleague of mine said, like, what is cisgender? Isn't that just normal gender? Like, why do I have to use cisgender? And it was like a learning moment, I think, for them to realize that. And I said to them, oh yeah, it's normal if you're cis. like if you're not, then it's normal to be trans or non-binary or two-spirit or any of the myriad identities that exist, right? And so this workshop I did was really about like unpicking like what makes you feel good about who you are. Like,
Mm.
so with this group of women, we talked about gender euphoria. Like, how do we get away from the deficit idea of like, oh, people who are trans or non-binary have gender dysphoria. They
Mm.
feel bad about who they are because their gender doesn't match what they were assigned at birth. When in fact, a lot of trans and two-spirit and non-binary people actually do feel good in their bodies. And I would say like a lot of cisgender people also, you get a great haircut, you get a new pair of shoes, a good top, that's gender euphoria,
Right.
right? And so how do we make sure that we're not like narrowing the narrative around gender affirming care to just non-cis people?
Mm.
Because cis people also deserve gender affirming care. And I think about bodybuilders who want access to hormones. I think about menopausal women who want access to hormones. I think like gender affirming care can be so much more than just caring for trans and non-binary individuals. And so I'd love to see the narrative um, around gender affirming care to be expansive and inclusive of all of our relatives.
No, I love that. It's so interesting you mentioned that because so I do work around education around anti-Black racism, right?
Yeah,
And understanding issues of race. And there's a, decolonial component to that. But when I speak to healthcare audiences, I'm like, first of all, if you do like Indigenous cultural safety, like obviously that helps you better treat Indigenous patients, but it helps you become a better practitioner and treat
yeah,
everybody better because it's humanistic, right? And when you learn about Black health, anti-Black racism, critical race theory, all of those things, it also makes you a better practitioner. You'll understand Black health. It's unapologetically Black, but you're going to understand and better treat patients. And I think what I'm hearing from you is almost the same
yeah,
vibe. Like if you understand components of gender affirming care, which probably the group that needs it most are people who are trans and
right.
non-binary. But if you have that competency and that skill set, you can be so good at helping your patients along their life journey. And what's coming to mind is also as men get older and their testosterone is dropping and they're wondering what that means, or for women as they're aging and their estrogen, you know what I mean? And menopause,
Absolutely.
because there's all this stuff that we carry around gender and our identities and not feeling like we're part of the norm in some way.
Yeah,
So that is a skill set that if we can better treat, patients in a particular group, we're better. It's that kind of like humanistic, I see you and myself
yeah,
kind of care. I love that. I love
yeah,
it.
absolutely. And I think even, I think about this a lot too, like even expanding our view of health to be beyond just people, like starting to
Mm.
think about our environments and how those things impact on our health and our gender and um, our way of being as humans being in a complex network of living things. Yeah,
Oh,
it's
like
pretty amazing.
can you like dive in, because I'm nodding and I'm like, okay, because we're part of the ecosystem and environmental health, but I feel like I'm missing a piece here. So do you want to kind
Yeah.
of
Well,
unpack?
I think about like what you asked about sort of incorporating traditional knowledge and like from my work with elders and knowledge keepers here in Alberta, and absolutely there's different traditions for every nation around Turtle Island, but
Mm-hmm.
a lot of our medicines are similar, and a lot of our medicines are like are caught up in like our natural environment.
Mm.
So we do a lot of land-based healing and education, and so it's about kind of getting out of the hospital, getting out of the clinic, and getting onto the land and into that network of living things that also support us. And it's really expansive. Like it's about like thinking about where our food comes from. You know, we talk a lot in health and public health around nutrition, and like I think about food deserts in large cities. You know, prior to colonization, there were no food deserts. There were deserts where there was limited food, but nobody lived there, or very few people lived there, right? They went where the food
Yeah.
was. And
Yeah.
so when I think about like the intersections between things like anti-blackness, like redlining and food deserts within cities, and all of those things are connected,
Yeah.
right? So it's this broader sort of environmental health in sort of like Eurocentric Western terms, but from an Indigenous lens, it's kind of like thinking about how do we relate to all of these living things that influence our health, like the food, the land, getting out. You know, I see memes all the time. Oh, get out and touch some grass, Karen, or you know, like, and it's true. It's medicine,
Yes.
and there's lots of evidence. There's lots of medical evidence and research that supports
Yeah.
that. So
Yeah, and hugging trees. Even my kids came home and they're like, "Mommy, we have to hug trees. It'll help our brain." And I'm like, "All right, let's go. Let's do this."
right?
We have a favorite tree in the park, but um, and I think no, I love the way you put that, and even the concept of food deserts. Like I'm learning to use the term food deprivation
Right,
or healthy food deprivation because the desert is naturally occurring,
right.
but this is like intentional, like you said,
Oh, I
redlining
love that.
or what have you. It's not mine. It's not mine. It's
Yeah.
from like African American scholars, but
Yeah, that's brilliant because actually there are lots of desert dwelling people who live just fine in a desert.
that's it. It's when you
Right?
said it, I thought about it, right? Like, yeah, these are structural, intentional ways that cause suffering. But I want to let folks know because we're at 7:21. If folks have questions for KD, and also I want to highlight. It was an error. Somebody like a typo. It says KR King, and I just want to like highlight that was an error, and we'll fix it on after. But like at the top,
Yeah,
you
no
might see
worries.
KR King at KD. So I know that.
KR sort of reminds me of JR from Dallas. I don't know if anybody ever
Now I
watched
know how
Dallas.
old you are. Yes, because I know exactly what you're talking about, and nobody in our audience has any idea what we're talking about.
Probably not.
But, but if y'all have questions for KD, please do send them in. There's this thing where people wait until the last 5 minutes, like
Yeah,
always.
yeah.
But please bring in your questions for KD around, I mean, so many things, right? Like sexual health, indigenous health, mental health, substance use, gender and sexuality. So I hope you folks will bring in your questions. In the meantime, though, I wanted to maybe, did you want to dive a little bit more into your research around
Yeah, sure.
HPV and what you're doing so people can hear about the research that you're
Yeah.
doing?
So as I mentioned, you know, I did a master's in epidemiology after I finished my nursing program, and one of the interesting things about that work was that I learned a lot about statistics and how those things work. But one of the things that really stood out for me when doing epidemiology was like how reductive
Mm,
that process
yeah,
is. Like it really does not account for diversity. And in fact, often diverse people and their stories are excluded as outliers or as, you know, there's like we're running into some problems on a research project I'm doing around two-spirit health where the bin sizes are too small because too few people in the census identify as two-spirit. So, you know, this big national survey said, well, we can't give you that data. The bin size is too small.
yeah,
Well, if we never look at that data, we're never going to know what two-spirit health is, right? So
correct.
applying this knowledge of statistics to my PhD research, I was really interested in HPV prevention, particularly around vaccination. And so I've sort of dug into the Métis community here, you know, making connections with kin. And I've done it I'm using a Métis research methodology called Ayahkwew, which just means visiting.
Sorry,
So
means
in
what? Repeat?
visiting,
Visiting.
visiting,
Oh,
yeah.
okay.
And, you know, the term Keokewan is an ancient term. It comes from the language Michif, but, and Cree. And it means the way we exchange knowledge when we sit together and talk. And so this methodology enabled me to go out and meet with Métis families all over the province and with them about their experiences with HPV prevention, and then also do a survey with the Métis Nation here in Alberta around attitudes and beliefs around vaccination, and then also do some administrative data analysis around actual vaccine coverage for Métis people here, all in partnership with the government and the Métis Nation and our community members. And it's such a great, honestly, it's made doing this work so much more enjoyable because we do everything in this like really kind, gracious way with food and visiting around the kitchen table. And when I meet with our research partners, you know, there's always food and tea or coffee, and we're just visiting about what's going on, and it's a really cool process. And I really am grateful that I've been able to reconnect with that and to start bringing Indigenous ways of doing research to sort of a provincial and national lens. So it's pretty exciting. The results will hopefully be out this summer. And yeah, and it's just been really amazing connecting with community members and learning about their experience with public health, because anti-Indigenous racism, gender-based violence, there's actually so many complex nuances to HPV prevention, because there's sexuality taboos, and you know, Catholicism plays a role, and then colorism in the Indigenous community, and anti-Indigenous racism from the public health departments. Like it's really wild. It's been a fascinating process.
But it's so powerful. And I'm hoping folks, because people always have like questions around research. I hope you folks, if you have questions, because this is disruptive research. This is not what where I've even tried to just do Black health research. It's been so many barriers. So I can't imagine doing this type of research around Indigenous health, Métis health, and then doing it in a disruptive manner where it's about visiting and it's about bringing in different forms of methodology and still being able to get the grants and being able to publish, because there's all ways that, you know, we get blocked along the way, the barriers. So congratulations on that. And I'm just wondering if there's any questions in the audience, because I also have a master's in public health and epidemiology. And I think it's so important for us to, yes, be in these spaces and learn these things, but then realize where the gaps are and change the game, you know, like change the way things are going. Okay, it looks like there is a question and I missed it, so I'm gonna scroll.
Yeah, it looks like
Missed
Tess
a
was
question.
asking
Where is
about
it?
gender affirming care and HRT.
Ah,
So
good.
as a registered nurse in Alberta, I'm not able to provide HRT or gender affirming care. However, if I was a nurse practitioner or a physician, and I think even some prescribing pharmacists do that work. But my experience working with lots of trans and non-binary people and two-spirit people who, you know, as a nurse, so in the clinic that may do HRT, is that we don't have enough providers. It's really hard to get in. There's a long wait for most providers here in Alberta. And when you do get in, there's still lots of hoops to jump through. But I'm hopeful. You know, here in Alberta, we've got some really wacky anti-trans policies on the table, and I've been doing a lot of community advocacy work around that to try and increase access. I know we have a brilliant Indigenous Nehiyaw physician, Dr. James Makokis. You may know him from Amazing Race Canada. He has made very public statements around, you know, providing gender affirming care to youngsters or to young people on reserve, because the sovereign nations are able to do what they want separate from provincial health policy. So, you know, I think there's a lot of exciting stuff happening around gender affirming care in Canada. Some of it's very nerve-wracking and anxiety provoking, but I'm hopeful that all this conversation will actually lead to better legislation and possible, you know, some legal challenges that make it set precedents to enable people to get better access to care. Because that's what we need for everyone, like literally for everyone.
Yeah. I had an interest in this area when I was in medical school, but that was a long time ago because I'm old, y'all. So I could just say I just remember going to like a private clinic where they did, you know, provided gender affirming care, and people would have their surgeries. But at that time in Montreal, it was people who had money, like lots of money. Like I did see diversity in those spaces, but it looked like people had somebody who was paying for them or what. It was quite expensive back then. And then when I worked at 410 Sherbourne, shout out to 410 Sherbourne at St. Mike's in Toronto, I provided
We love
hormone
them.
therapy to folks who were transitioning, and there was a lot of emphasis on pathologizing them, like not at 410, but to be able to qualify for the surgery, right? This idea of gender dysphoria, and you had to prove all of those things. So I'm glad that those things are changing now, and but there's so much to be done. Like we're
Yeah.
so behind of what people need, but it was much worse before.
Yes.
That shouldn't make us feel any better. I'm just saying that I'm hoping that we move even faster towards progress than what I saw in the last 10 years.
There
I hope we
is
speed
some
it up.
progress being made, Dr. O, because like I know that more and more like work provided health benefit providers are covering gender affirming care. So they'll cover HRT, they'll cover some surgeries, and also provide like recovery time within their insurance policies. So there is movement on that. And there's been increased, I think, push from corporate, different corporations to say that we want this included in our benefits package. We want to be inclusive. So I do see that shift happening, but it is, as you said, it's still very difficult to access. And currently in Montreal, for some transitional surgeries, they're only available there. So it is really, really hard to get. And the wait lists are very long.
I can imagine. Yeah. I wonder if folks have other questions, but I'm just, yeah, I love a gender euphoric future. I think it, for me, it's analogous to also the concept of Black joy. And then I
Yes.
guess if you're have the intersection of being like Black and trans, and it's just like euphoria, joy, all of those
Yeah.
things. Because it's this need to kind of pathologize people and make them feel miserable in their skin, and in who they are. And let's see the joy, let's see the celebration, and let's see better access to affirming care.
Yeah.
Um, yeah, so we're at 7:31. We usually close at 7:30, but I'm curious if there's any other questions about nursing, disruptive research work. So we'll just stay on a couple more minutes in case
Sure.
folks have questions. Um, and we'll definitely want for our newsletter just a little bit more about the type of research that you use, just in case some of our readers are curious about that, like the
Yeah.
visiting kind of
Yeah,
research.
no, I can send you some links to some of the seminal, like published articles. Cindy Gaudet is the researcher. She's here at the University of Alberta. She works at Campus Saint Jean, our French-speaking campus.
Mm.
But her research really centers Métis women's wellness, and she does a lot of work around language revitalization as wellness, around gathering as wellness, and visiting is the methodology that informs all of her work. And it's honestly since there's this group called Litab Otapemsawak, which is like the kitchen table of the people who rule themselves,
Yeah.
which is another word for Métis people, the Otapemsawak people, the people who rule themselves. And, since joining that table, it's just been transformational for me, both as a scholar and as a human being. um, especially because it is very femme-centered. Like it's women's knowledge, it's women's ways of doing, or femme folks' ways of doing. Because I think a lot of our 2S trans, non-binary, and queer folks also probably, they fall into that way of generating knowledge through kinship, and
Yes.
it's really wonderful.
Yeah, no, it's a beautiful thing. Okay, it looks like I think we don't have any other questions. This is the last call. If anybody has any questions for KD, if not, then we'll wrap up. And yeah, I'll follow up with you for some terms and resources
Yeah,
that we can put in the newsletter. But otherwise, thank you, KD,
thank you
for
for
joining
having
us.
me.
Yeah, this is great. Okay. So yeah, thank you. Have a good evening. And folks, please tune in next week. Our guest will be a nurse, researcher, and leader, actually, again. And so we have another nurse, leader, and researcher, Dion Sinclair. So thanks, everyone.
Awesome. See
Have a good
you.
night. Thank you, Katie.
Thank you. Bye bye.
Bye.